Welcome to the IHH webinar series. I am Spero Cataland, Professor of Internal Medicine in the Division of Hematology at The Ohio State University. I'll be joined today on this webinar entitled Case Consult Optimizing the Management of Congenital TTP by my two colleagues and friends, Marie Scully, who's a Professor of Hemostasis and Thrombosis at the University College of London, the clinical lead for hematopathology and blood transfusion at London hospitals in the UK. And Dr. Shruti Chaturvedi, who is Associate Professor of Medicine, Research Director in the Division of Hematology at Johns Hopkins University in Baltimore, Maryland. Here are the learning objectives for today's webinar. To recognize common issues faced by patients diagnosed with congenital TTP, including the high burden of disease during acute episodes, manifestations during subacute episodes, and long-term organ damage. To evaluate the benefits and limitations of our current treatments for congenital TTP, and also to select the best prophylactic treatment for congenital TTP patients to prevent subacute manifestations and long-term organ damage. We would like today's webinar to be interactive, and we encourage you to submit questions to our presenters using the Q&A button at the bottom of the Zoom window. Feel free to submit your questions at any time, but please specify which speaker you would like to address the question to. If you're experiencing technical problems with the webinar, you can use the raise hand button or contact the France Foundation via the chat function. Here is our agenda for today. You can see that after a few knowledge check questions, Dr. Chaturvedi will begin by discussing the burden of disease and treatment of congenital TTP, followed by Dr. Scully talking about treatment approaches of congenital TTP, and then I'll discuss patient considerations in the treatment of congenital TTP. Okay, so let's go ahead and get started with the first question. Which of the following is a potential long-term complication of recurrent congenital TTP episodes? Lung fibrosis, recurrent strokes, liver cirrhosis, or bone marrow failure? Okay, the second question, how might recombinant ADAM-TS13 therapy potentially impact the quality of life for congenital TTP patients? By increasing the rate of plasma transfusion, by allowing for oral administration at home, by curing the underlying genetic defect, by reducing the frequency of hospital visits. I'll give you a second again. And the third question, how can a healthcare team best manage the trade-offs between treatment efficacy and side effects in congenital TTP patients? A, by including psychological evaluations in follow-up care. B, by regularly assessing and adjusting the treatment based on patient feedback and side effect profile. C, by choosing the most effective treatment regardless of side effects. Or D, by referring patients to community organizations for social support. Very good. With that, I will stop and turn it over to Dr. Chaturvedi for her presentation.
Let's start with a case study of a fairly typical patient. This is a 22-year-old female who presented to the emergency room with a headache, nausea, and abdominal pain. She's also pregnant at 13 weeks of gestation, so just into the second trimester here. She has a medical history of stroke at age 18, and we don't really have much detail around this event, as well as headaches. Her family history is notable for diabetes in her mother and a fairly early stroke at the age of 55 in her father, and her only medications are a prenatal vitamin. When you get urgent blood work in the emergency room, you see that she has anemia with a hemoglobin level of 8.5 grams per deciliter, a platelet count that is very low at 13,000, and as far as you know, this is a new issue. Her serum creatinine is at 1.1, which is close to normal, but her LDH level is several times normal, indicating a likely hemolytic process contributing to the anemia. She has normal coagulation studies, a suppressed haptoglobin level, and an MCV of 89. And then as a hematologist, you get a blood smear, and this is what you see. There is an abundance of these red cell fragments or schistocytes, indicating a microangiopathic hemolytic anemia. And what we don't see here are platelets. You're also seeing some polychromasia, indicating the reticulocytosis. So let's move on to a question here. You can use the QR code to answer it. What do you think is the most likely diagnosis? Could it be the HELP syndrome of pregnancy, thrombotic thrombocytopenic purpura or TTP, preeclampsia, atypical hemolytic uremic syndrome or ITP? I'm going to briefly go through some of these, although since we are talking about TTP, that is the most likely answer, but that's not the only reason. She's rather early in her pregnancy to have the HELP syndrome, which tends to occur usually in the third trimester or at least after 30 weeks. TTP is quite likely given that she's presented with profound thrombocytopenia with platelet counts that are less than 30,000 with basically preserved renal function in the setting of a microangiopathic hemolytic anemia. It's also too early for preeclampsia. With atypical hemolytic uremic syndrome, I would expect to see more renal impairment, and it also tends to present later in pregnancy. And finally, immune thrombocytopenia doesn't quite fit this picture because she also has significant anemia and clear signs of a thrombotic microangiopathy on her blood smear with the schistocytes. So moving on, what treatment would you start? Deliver baby, plasma infusion, plasma exchange, eculizumab, or corticosteroids? Once again, we have a QR code to help you answer the question, but just going through these, it's a little early to deliver the baby. The baby would likely not survive at 13 weeks, so almost certainly not survive. Plasma infusion and plasma exchange are the two options that we really think about when we're thinking about TTP. But in this first episode, the day the patient presents, it's essentially impossible to know whether it is congenital or immune TTP, so plasma exchange is the safer answer over here, right? So let's move on to an overview of thrombotic thrombocytopenic purpura. We know that it's a rare disorder characterized by episodes of systemic microvascular thrombosis that present clinically as thrombocytopenia, along with microangiopathic hemolytic anemia and variable degrees of organ dysfunction related to that ischemic injury. Now, there are two types of TTP. The more common form is the acquired or autoimmune TTP, which is caused by autoantibodies against ADAMTS13. The minority is congenital TTP, which is quite rare and is caused by biallelic mutations in the ADAMTS13 gene. And it's also referred to as hereditary or HTTP, and this is the subject of our discussion today. Now, congenital TTP, as I just mentioned, is ultra rare. The incidence is less than 1 per million population, and it is inherited. It's genetic deficiency of ADAMTS13. While it is the rarer form of TTP, and in fact, less than 5% of all patients with TTP have the congenital form, its relative prevalence is higher in certain groups. So if someone presents in the neonatal period or in early childhood, it is more likely that they have congenital TTP. Also, in women that present with TTP the first time that they get pregnant, the relative prevalence of congenital TTP is more than 5%. It's almost 1 in 4 women who present in their first pregnancy. Now, when we think about the clinical presentation of congenital TTP, the most obvious thing that most of us think about are these episodes of microangiopathic hemolytic anemia, thrombocytopenia, and end organ damage, the clinically overt episode of thrombotic microangiopathy. And we know that they don't have to be present all the time, but exacerbations occur during periods of stress or during periods where von Willebrand factor levels increase, and hence the balance of VWF and ADAMTS13 is disrupted. These higher risk periods include the neonatal period, pregnancy, infections, alcohol use, and also vasopressin use. Now, congenital TTP, while it can present with a really severe thrombotic microangiopathy similar to immune TTP, there are certain differences too. Congenital TTP may present with a less acute or a milder clinical course and lab presentations. And in contrast to immune TTP, acute kidney injury is slightly more common. Interestingly, it is possible to have a neurologic event without thrombocytopenia altogether, and many patients are asymptomatic, particularly between episodes. Now, these episodes of congenital TTP can occur throughout the lifetime of an individual. Data from the International HTTP Registry that includes 87 patients tells us that the incidence of acute episodes is about 0.35 per person year. And there seems to be an earlier age of onset of these episodes with patients that have mutations in the pre-spacer region versus the post-spacer region of the gene. The highest incidence is actually at less than 10 years of age, and contrary to what I would have expected, the incidence doesn't actually increase with age. It seems to decrease in older patient groups. Now, what you're seeing in this graph here is, although I've been talking about the early incidence here, there is really a bimodal distribution. There's a first peak in early childhood with a median peak age at about 3.5 years, which also coincides with early childhood infections. And then you have a second peak that is driven by young women that get it during their first pregnancy, and the median age here is 31 years. Patients that present younger tend to have more severe organ damage compared to patients that present later in age. Now, in addition to these acute episodes, patients with congenital TTP also report a large number of chronic and more subtle symptoms. These include things like persistent thrombocytopenia, unexplained headaches and migraines, which occur both in about a fourth of individuals, as well as lethargy and fatigue. A large number, at least 11%, have stroke and transient ischemic attack. Abdominal pain and then recurrent episodes of microangiopathic hemolysis are common. So this burden of TTP includes acute TTP episodes, but also more chronic symptoms, as well as cognitive impairment, depression, and also increased mortality that I'll just show you. Now, in addition to these more chronic and subtle symptoms, there's actually an increased rate of overt stroke and myocardial infarction in individuals with congenital TTP. Rate of stroke is increased at approximately 20% in the international and UK registries, a much higher rate of 63% reported in the United States registry, but this was a registry where patients were asked to respond to questions or respond and participate in the registry, so there may be some responder bias where more severely affected patients may be responding. The TIA rate ranges from 10 to 19% here. The International TTP Registry reported a 4.2% rate of myocardial infarction, but this wasn't reported in the others. And we've seen in congenital TTP that stroke, as you see from the table, is more common than myocardial infarction, and this pattern is also recapitulated in immune forms of TTP. What's also seen, as you see in the figure over here, is that these events start fairly early in life. You're seeing 11% having a stroke before the age of 10, and by the age of 60, essentially 100% of individuals in follow-up have had a stroke, showing that events are not only more common, but they also occur earlier than would be expected in the general population. Now, based on these observations in congenital TTP, as well as observations from immune TTP, where we know now that lower levels of ADAMTS13, even during the remission periods of immune TTP, increase the risk of cardiovascular disease and stroke. For example, the risk of stroke is 5-fold at a 3-year follow-up compared to the general population and is associated with low ADAMTS13 in remission. Based on this, we have this model where you can have really low levels of ADAMTS13, where you're at risk for clinical episodes of thrombotic microangiopathy, or you could be normal. But in the middle, you could have subclinically low levels of ADAMTS13, even if they're not low enough to cause overt thrombotic microangiopathy. Anything below normal, including the people that run below 10%, do have persistence of large VWF multimers during remission. They can have subclinical platelet activation and aggregation and endothelial activation, which eventually leads to cumulative vascular injury and lowers the threshold for events such as stroke and myocardial infarction. Now, I mentioned earlier that kidney involvement is somewhat more common in congenital TTP compared to immune TTP. From the international registry, 21% of individuals were reported to have renal disease, and 43% of these patients with renal disease develop chronic kidney disease after having episode after episode that was complicated by acute kidney injury. So essentially, multiple episodes of acute kidney injury culminating in chronic injury. And the majority of patients with kidney injury also had other comorbidities, but there was no correlation really between the onset of chronic kidney disease and the comorbidities. In addition to all of these morbidities, patients with congenital TTP actually have shortened survival. What you're seeing in the graph over here in the green line is probability of survival in patients with hereditary TTP. The blue lines just mark the bounds of the 95% confidence interval. The red line here is survival in an age and sex matched population without congenital TTP. And you see that there are clear differences in survival over here. At the age of 10, patients with congenital TTP, about 92% are expected to be alive compared to 99% of unaffected controls. And by age 40, the difference is much greater at about 82 versus 96%. So to summarize the clinical burden of TTP, the tip of the iceberg is the episodes of microangiopathic hemolytic anemia with thrombocytopenia, the overt TMAs. And then you have the episodes of thrombocytopenia that are picked up on lab work. But below the surface, patients also have a really higher rate of cerebrovascular events or stroke and myocardial infarction. When they get pregnant, these pregnancies are complicated by preeclampsia, fetal loss, and acute episodes of TTP. And things that we don't talk about enough, but the patients report are symptoms like fatigue, headache, and cognitive impairment that lead to significant morbidity and impaired quality of life. Thank you very much. And now Dr. Scully is going to talk about treatment in congenital TTP.
Thank you, and good afternoon, good morning, wherever you are in the world. For the next few minutes, my mantra is to discuss treatment approaches to congenital TTP. So as an overview, we have three main therapies. One includes plasma therapy, either plasma exchange during acute TTP episodes or plasma infusion, which can treat acute episodes once we know that patients have congenital TTP. Two, we have intermediate factor VIII concentrates. While very good for the use in younger patients with cTTP, avoiding the need to come into hospital, the amount of ADAMTS13 present in these factors is very small. And finally, as of the end of 2023, we have recombinant ADAMTS13. So plasma transfusion can be used to either treat an acute episode or exacerbation of congenital TTP, but also it can be used in the prevention of acute, subacute, and non-overt symptoms. And the variability depends on a number of factors which are relevant to many different countries and continents. But essentially, up till now, the mainstay of therapy has been a blood product. With that, we do see some complications. But first to say, the development of alloantibodies to ADAMTS13 with the use of plasma is extremely rare. And they don't appear to affect ADAMTS13 recovery or the plasma half-life. However, it is a blood product, and there remains, even with the most protected plasma, the risk of transfusion of infections, both pathogens we know about and those that we don't know about. There are other risks associated with FFP, and probably the most relevant for patients and clinicians are reactions. And these can vary between 5.6 to 72 per 10 to the 5 units transfused. And often when patients have one set of reactions, particularly to untreated plasma, they develop further reactions and require pre-medication, which in itself is not without side effects. So when should we use plasma transfusion? This has to be a case-by-case clinical decision. And it will depend on the physician's understanding and experience with congenital TTP. Should we only treat symptomatic patients, i.e. when their symptoms are significant enough to warrant initiation? Or should we suggest giving patients plasma when they're asymptomatic and they have no symptoms? And there are arguments pro and against both these options. But from our previous talk, you can see the impact of ongoing low ADAMTS13 activity levels. And even if patients don't have obvious symptoms, acute symptoms, longer term, there is evidence of end organ damage. The next consideration is whether we should start all patients on an ADAMTS13 replacement pathway at diagnosis, or we only do it after they demonstrate complications. Again, there's pros and cons for both options, but I think ultimately we need to consider a pathway which is preventative. Then we have situations which require special consideration. The one you've already heard about is pregnancy. absolutely all patients with, or all ladies that are pregnant and known to have congenital TTP should have ADAMTS13 replacement throughout pregnancy. That now is relatively established, but there are other situations such as covering surgery or unwell in hospital because of a non-surgical precipitant. So I have a case study, and this is a real patient. He's a 15-year-old male who was diagnosed with congenital TTP following family screening. He claims, and his family claim, he's completely fit and well. And then he was asked about specific symptoms. And actually, he did have recurrent abdominal pain, which was central in nature, was excruciating, and used to come out of the blue, lasting from minutes to hours. He did have headaches, and these sometimes went on for hours or at low level for days. He felt very lethargic compared to his peers, and in fact, he had 2 episodes of loss of consciousness. But reviewing his platelet count on a number of occasions, this was completely within the normal range. So how would you manage this young man? So if you'd like to scan the QR code to answer the question, the options are just watch and wait, only treat him if he has an acute TTP episode, start an ADAMTS13 prophylaxis schedule, and discharge. He's at no risk, he's male. So going back to plasma transfusion, how much and how often? Another very pertinent question. Now we know that ADAMTS13 as an enzyme has a very long half-life. But the optimal level of plasma ADAMTS13 activity to maintain 1, a normal platelet count, and 2, to manage complications, both acute, subacute, and non-overt, is unknown. When giving patients FFP, the mantra is between 10 to 15 mils per kilo of plasma. Personally, I think 10 mils per kilo is enough. 15 mils per kilo could certainly aggravate fluid overload. But either way, the ADAMTS13 activity level, which does not normalise, returns to the baseline within 5 to 10 days. And how often? The most common prescription based on the long half-life of ADAMTS13 is 2 to 3 weeks. So yes, this possibly could control clinical and laboratory manifestations. It's more convenient and there's less resource utilisation. And there's no evidence to support or refute the exact timing. But is it enough? The alternative is just to give patients therapy episodically on demand and around known triggers. So for example, if they have a viral infection or a procedure. We've already discussed about pregnancy and congenital TTP. And we've known now for a number of years that the fetal outcome and indeed the maternal outcome is poor if we do not ensure that there's ADAMTS13 replacement throughout the pregnant period and the postpartum. Starting with infusions of 10 mils per kilo every 2 weeks during pregnancy, one would not normally need to increase this to weekly, certainly in the 3rd trimester, but in part guided by the patient's previous obstetric history. And there are some cases where maintaining the blood counts and fetal well-being can resort to plasma exchange. And these patients need very close monitoring in an expert centre with the neonatal team and obstetricians at hand. Again, looking at the international and the UK TTP registries of congenital TTP, both which have the largest cohorts to date, not all patients were on a regular plasma prophylactic schedule, and indeed from the international registry, there was no difference in the annual incidence of acute TTP episodes, whether patients received regular plasma or not. But I think this is a reflection of starting therapy based on the patient's clinical disease. And we do know that there are patients who have a milder phenotype. From the UK registry, there was a reduction in symptomatology as demonstrated in the table. But the reasons for starting prophylaxis, in about a quarter of cases, it was because of recurrent thrombocytopenia based on levels below the normal laboratory range. But 2/3 of patients, it was because of symptoms, non-overt symptoms. And these were significantly reduced if plasma infusion was started regularly. And certainly the evidence for reduction in end organ damage has been shown both from the UK and the international registry. Other considerations with plasma, these are obvious. The need to go to hospital or an infusion clinic, it takes a number of hours to complete every week or 2 weeks, which can really impact work, school, social activities, never mind the cost and the inconvenience, plus the impact on the quality of life, particularly if patients are beginning to have reactions to the plasma. The need for intravenous access, it can be very traumatic, having to have repeated venipuncture, which becomes more and more difficult with time. And the use of permanent lines, while attractive in their own right, have a number of complications. And finally, the availability and safety of plasma. So recombinant ADAMTS13. This is manufactured with no additives of human or animal origin. And it's a very small intravenous bolus that's usually given by a butterfly. And it's furthermore suitable for home therapy. The initial study, which was a proof of concept, giving 1 dose of recombinant ADAMTS13, demonstrated that the enzyme activity increases, and further animal studies have demonstrated efficacy and safety. So from this phase 1 study, we can see following 1 dose that patients achieved essentially a normal ADAMTS13 activity, which is unachievable with current therapies. It was well tolerated, and the pharmacodynamic activity demonstrated that the activity persisted for much longer than in patients who receive plasma infusion. The phase 3 study has been completed, and this was a crossover study with standard of care, and the final 6 months patients received recombinant ADAMTS13. And the approval in 2023 by the FDA and subsequently by EMA has been for adult and paediatric patients with congenital TTP. Starting on a 2-weekly basis, there is an option to increase this to weekly if patients need it because of clinical situation. And from this pivotal study, we can see that all those non-overt symptoms and subacute episodes were significantly improved. But moreover, the length of time that we're seeing ADAMTS13 present is much longer than with standard therapy, so 5-fold longer than with FFP. And that's keeping the ADAMTS13 activity level above 10%. With regards to adverse effects, if we look at the table once again, one could attribute many of these adverse effects to be associated with TTP non-overt symptoms. And there were no hypersensitivity reactions seen in patients receiving recombinant ADAMTS13, which is at variance to those who receive standard of care. and it has been used in patients who were pregnant. It was not part of the pivotal study. 2 patients on the study on the long-term extension became pregnant. One of them had a miscarriage, which was unrelated to recombinant ADAMTS13, and the other delivered a healthy baby, but both stopped therapy during pregnancy. But subsequently, it has been used very successfully in patients on a compassionate use basis. So, when discussing prophylaxis with patients, what barriers have you experienced related to their understanding and acceptance of the benefits of this new therapy? And the QR code is there once again. So if we go back to our case of our 15-year-old young man who was picked up through family screening, what should we do? We can watch and wait. That is possible. Personally, I don't feel it's ideal, but many physicians will opt for this option. Only treat if you have acute TTP episodes. Yes, but again, not ideal for the reasons that we've already discussed. Start ADAMTS13 prophylaxis schedule. For us, this would be the ideal situation. Discharge, no risk as young and male. That's absolutely not how we would want to manage patients with congenital TTP. ADAMTS13 replacement should be offered to all patients with congenital TTP. Now, the timing of when they start a prophylaxis pathway will very much require continued discussions and may not be immediate. For this young man, recombinant ADAMTS13 was not available, which is a real shame as he'd never been exposed to blood products. And so he started a trial period of 10 mils per kilo weekly of FFP. And what was demonstrated is that he had no ongoing overt symptoms, he had more energy, and he felt better. So what is the future plan? Thank you very much for your attention.
Well, thank you, Marie, for that excellent presentation, and as well to you, Shruti. So it's in my presentation today, what I'll be talking about are the patient considerations in the treatment of congenital TTP, and maybe a different way of looking at the data that we're all aware of. Let's see. So this is a very interesting study that was put together, starting with a literature search to know and understand the most relevant symptoms patients may experience from the published literature. It was then refined by interviews with expert clinicians in the field who take care of these patients. And then patients were recruited, about 10 to 12 patients were recruited and were asked regarding these symptoms of congenital TTP. And they were asked to rank them on a disturbance rating, the average disturbance rating, so 0 to 10, with 10 being the greater disturbance. So what you can see here in the surveyed patients is the number of mentions, as well as the length or the severity of the disturbance. And really what you see is the most salient symptoms that are reported by patients are fatigue, headache, joint pain, forgetfulness, difficulty communicating, which is likely connected to the forgetfulness, as well as bruising. There are many other symptoms that you see, but these are the ones that were more commonly and more readily reported by patients. But looking at the symptoms and their impact, which I think is very interesting. Again, same study, same format, and you can see the number of mentions as well as the severity, the degree of the disturbance that was experienced by patients. And the most salient impacts on patients with congenital TTP, this reduced ability to work or study, feeling depressed, financial distress, mood swings, feeling anxious. And many of these may be related to the disease. They may be related to the treatment that they feel burdened by. So really it's a balance. It's concern about long-term outcomes potentially in patients that they're hearing about, but also understanding what's involved in the day-to-day, the nuts and bolts of having to do this to prevent these complications. And in fact, doing these things when we're informed but not certain of the efficacy of some of these measures. There are certainly burdens of the standard treatments on patients in patients with congenital TTP. Patients who require or are on plasma exchange for TTP, but more commonly, obviously, in congenital TTP plasma infusions, there's a significant burden. We may start patients out every 2 weeks with a goal of a normal platelet count potentially, but certainly we're starting to understand the goals, as you've heard earlier, are symptom control, both short-term but long-term prevention of complications. There are regular blood monitoring that's required, including the ADAM-TS13 activity and rarely hospitalizations. But these treatments, there are side effects to plasma-based therapies, especially rashes, hives, discomfort at the injection site. If they're on steroids, there's obviously side effects. But the vascular access to achieve a plasma infusion program can be quite burdensome as well, whether it's an indwelling line, rarely I've seen fistulas, but also just a peripheral line can be burdensome. So patients are going to have preferences regarding their treatments, the schedules that really fit in their lifestyles and their goals in life as well as work life. You're going to see a very much an individualized approach to managing congenital TTP patients. And I think this is a function of both the physician as well as the patient. Their ADAM-TS13 activities may give some guidance. They're really going to confirm that diagnosis. It's going to be what's available to the patient. Are they going to have access to recombinant ADAM-TS13? Or are they going to be using a plasma product or a factor VIII concentrate? You're going to talk about patient preferences in the context of what the physician believes. So the physician may believe weekly plasma therapy is required to achieve an ADAM-TS13 level that you need to prevent short-term symptoms or maybe long-term complications. But will the patient be willing to do that if they don't feel that direct benefit today? It's going to be a function of their comorbidities, other issues that they're dealing with, especially cardiovascular complications that may play into their risk for long-term complications. Age is very important, and certainly younger patients may not be on board necessarily with what they're going to be like in 30 to 40 years from now. And younger patients generally have a shorter time frame looking at things, whereas older patients may have life experience, dealt with the medical system, and are more willing and more wanting to prevent these complications since they've had to deal with some of them already. Quality of life considerations are important when you need plasma infusion regularly. And adverse events that they experience with their prior therapies are certainly going to temper their view on how they go forward. So somebody with frequent and severe plasma reactions is going to not be so excited about decreasing the frequency to every week or increasing the frequency as it may be for weekly infusions. You've heard this from Marie already, in the ADAM-TS13 activity that you can achieve with recombinant compared to plasma-based therapies, plasma infusion. And it's roughly a 5-fold greater time period that you're going to be over an ADAM-TS13 activity of 10% with recombinant compared to plasma. So it very much is difficult to really recommend, 10-day weekly plasma-based therapy, knowing that you really don't have that great achievement of the ADAM-TS13 activity that you're looking for. But as you can see with the recombinant ADAM-TS13, there's a greater time to being over 10%. It's a threshold, really has been extrapolated from immune-mediated TTP that we believe is required to prevent acute episodes. And again, preventing acute episodes is sort of the low bar that we want to get over. These arguments are going to change when we understand better the levels of ADAM-TS13 that we need to prevent subacute symptoms as well as long-term complications. I think it's important to mention there's a multidisciplinary team that usually has to help out, whether this is an official team put together at an institution or an unofficial team put together by the hematologist or the nephrologist that is the primary caregiver of these patients. There's generally providers, including neurologists, cardiologists, that are pulled in for complications, chronic kidney disease, hypertension, as well as for understanding the risk for long-term complications, cardiovascular complications, and maybe how to mitigate those in some way. When patients are pregnant, obviously, it's typically going to be a higher risk obstetrician that's involved, working very closely with the hematology team to get the patient safely through pregnancy, as well as nurses, social workers, and pharmacists. So truly a multidisciplinary team. Obviously, you want to rapidly recognize acute TTP episodes, but what really is more important is the long-term monitoring of the ADAMTS13 activity and the patient's symptoms and status. So managing their treatment, assessing their organ complications, their risk for future complications, and really amongst all the providers trying to convey to the patient the importance of trying to prevent some of these long-term complications with the therapies we have available today. So we go back to the case study that we described initially. This patient did well with the initiation of recombinant ADAM-TS13 at a dose of 40 units per kilogram given every 2 weeks during the pregnancy. Due to some increased symptoms, nausea, abdominal pain, it's important to mention that these can happen even with a normal platelet count. As she began the third trimester, she was switched then to weekly dosing with an improvement in her symptoms, which is encouraging. She delivered a healthy baby at 38 weeks, and mother and baby were both doing well. Recombinant ADAM-TS13 activity was planned to be continued at the same dose of 40 units per kilogram every 2 weeks for the first 8 weeks postpartum to cover during this postpartum time period, with plans for then discussion after all the excitement of the pregnancy, childbirth, and the new arrival to discuss with her hematologist at a calmer pace the need for long-term prophylaxis, and is it something that they are both think is important as well as for the patient willing to pursue. So some key takeaways from our program today. So without proper management, congenital TTP can lead to acute life and organ threatening TTP episodes, as well as more importantly, I believe subacute chronic organ damage. Plasma therapy can rapidly reduce the severity of these acute episodes by supplying the missing ADAM-TS13 protease and removing antibodies in the case of plasma exchange. But it's invasive. It requires frequent hospital visits, carries risks such as infections, and more commonly, allergic reactions and hypersensitivity reactions to the plasma. It's important to emphasize also that the ADAM-TS13 activity was sustained greater at a level over 10% with recombinant compared to the plasma-based therapies. Recombinant ADAM-TS13 may indeed address some current unmet needs in patients with congenital TTP, but certainly the levels that need to be achieved to prevent subacute symptoms, and I believe more importantly, long-term complications, really need to be done and studied in greater detail. Thank you very much for your attention. I will stop sharing.
Thank you so much, Dr. Cataland. We will now move on to our question and answer session. I have to thank our audience for being so engaged and coming up with these very insightful questions. I'm going to start with one from Dr. Lamley on the epidemiology of congenital TTP. And his question was, what do you think about the recent reports that report the much higher prevalence of congenital TTP from Italy? As a reminder for our audience, there was a recent paper that looked at genetic epidemiology methods to estimate the prevalence of congenital TTP and reported that in contrast to the approximately 1 per million that was previously estimated, the genetic epidemiology approach suggested that the true prevalence may be closer to 23 to 40 per million population. Dr. Cataland, what do you think?
I think it certainly makes logical sense and clinical sense when we look at there's nothing unique about females compared to males with this disorder other than they're getting pregnant and experiencing that second hit. And if males were experiencing a more frequent or regular or, if you will, predictable second hit, I think you might see that. I think it's kind of sobering. And I think there are many cases, and we've all spoken before about this, that we're likely missing, that the thrombocytopenia is just written off as consumptive from the acute stroke or from the acute illness, rather than kind of stepping back and saying maybe we should recheck these labs when recovery, or maybe check that ADAM-TS13 activity. So I think they're important data to help us maybe pay attention to what we're seeing.
Yeah, no, I agree completely. I'd also like to point out that, there was a recent publication that suggested that neonatal presentations of congenital TTP are often missed, and that may be another missed opportunity for diagnosis. Dr. Scully, do you have any additional thoughts on this?
Um, I agree that the incidence of congenital TTP is definitely going to be higher than we already know about. I mean, we've seen probably even in the last 5 years that more cases are diagnosed than they were in the 5 years before that. Whether it's 40 per million, I think maybe that is a marginal overcalculation, but it certainly is important that we highlight that there are going to be more cases. With regards to the neonates, I think there will definitely be neonates are being missed. I still think it's very, very rare.
Okay. Well,
Sometimes the hardest part is just thinking
yes.
about it, right? And I think
Yeah.
these data let us know to think about it more. Then you
Yeah.
can more easily diagnose it.
I suppose there's also the possibility that there are people who never see that second hit or trigger that makes them present, which is also sobering, but perhaps they present with early vascular disease that we
Yeah.
don't catch. A somewhat related question from the audience is, if you are able to identify a patient with a pathogenic mutation or two pathogenic mutations, would you start them on prophylaxis without history of any clinical events attributable to TTP?
That depends on what you mean by clinical events, I think. So, as per the young man, if you don't ask the questions, you don't get the answers. And he had a trial of FFP to see if it made him feel better. If you felt awful all your life, that's your normal. If you're giving ADAMTS 13 replacement and those symptoms disappear, it's really a black and white situation for patients. So the way I approach it is to try and give at least a trial to see if they feel better. And it will often takes months to years to engage patients to continue with regular prophylaxis. It's not something that happens instantaneously, but I think it's important that you can demonstrate well-being with ADAMTS 13 replacement, even if it's over a short period. And yes, we do give patients treatment as soon as possible if they will accept it.
All right. There are some questions here about what is the platelet threshold at your institutions to insert a central line. I'll start with ours. We actually do not have one, and we do not transfuse platelets unless the patient is actively bleeding. Do you do anything differently?
They don't bleed.
Yeah.
So with ultrasound, I don't think we need to give, we haven't done it for years. So yeah, I think that's pretty well established. I don't think there's a rationale probably for anyone to have a transfusion of platelets under ultrasound control these days.
Sounds good.
Yeah. I like to tell our clinicians that this is a different 5,000 than the leukemia 5,000, where they're not producing them. And even though you aren't measuring them, they are still producing them. And you just don't see routinely bleeding complications with a careful placement of the line.
Absolutely. Dr. Scully, there's a question related to the pharmacokinetics that you described for recombinant ADAMTS13. Dr. Aore points out that when you show the more sustained activity, it looks like the gain is mostly driven by the higher peak. Would more frequent infusions be a more efficient form of administration? And the second part of this is, how large is the variability of pharmacokinetics in the population? Do you think we could tailor the dose to the needs similar to hemophilia?
I think they're both excellent questions. Absolutely, we're seeing a longer time of ADAMTS 13 above 10% because we're achieving proper levels, which we cannot do with current standard therapies of ADAMTS 13 replacement. Obviously, a trial is a trial and you have to follow the protocol. I think that there will be changes afoot in the future. And whoever asked the question brings up a really important point. I think that we need to consider more frequent infusions, possibly at a lower dose, trying to achieve an ADAMTS 13 near normal. I mean, that's what we want, is normality, to prevent not just acute TTP episodes, which we now know are not as common as we originally thought, but everything else. A lot of things in place, including the way that we give the infusion, home therapy, possibly subcutaneous, that would be the ideal. But I think achieving a much higher ADAMTS13 level with more frequent dosing, possibly lower than that, that we used in the trial, is the way forward.
Sounds good. I have a somewhat related question for the both of you. Given that the clinical trials did not look at impact of recombinant ADAMTS13 on these longer term outcomes, what is your best guess in the absence of great data as to the best target ADAMTS13 level? Is it truly normal? Is it slightly below that? Or is it high normal based on the population studies that show that even, you and I may have differing levels that will impact our vascular health?
Go on,
Dr.
it's Spero, before you
Yeah,
have another
I
answer.
mean, I know Maria's answer is going to be normal. I agree. I'd love to see normal.
Mhm.
Um, but I think this is always a negotiation, especially in the patient who may have been diagnosed without, or they feel they aren't symptomatic. They may be, they just don't realize it until they get on treatment. But it's a negotiating process, and I think it's negotiating with the patient what they'll put up with, as well as can home therapy be given, as well as data that's going to be needed to convince insurance providers that it's important because they're going to want to spend less money, obviously, is their ultimate goal with this disease. Um, I think it's an excellent question. I think we're going to be moving forward in a period of more aggressive prophylaxis to achieve at least half normal levels until there's data to support it. And because of the rarity of the disease, I'm certain we'll have retrospective studies that are going to be put out in the next 10 to 15 years based on the presumption of this approach that I think most people, you can say there's no data, but I think most people believe that to be true. So I think preventing symptoms, not just thrombocytopenia, is important. Then I think we need to prevent those long-term complications, which are the bigger issue in a younger patient that's diagnosed with 60 or 70 years ahead of them.
Do
Marie,
you
what do you
think we
think?
can
I'm sorry.
extrapolate from immune TTP? Do you think that's a reasonable strategy until we have more data?
I think so. I think so. I think we're still learning the nature of these complications. They are driven primarily by ADAMTS deficiency, but there's other factors as well. So I think this is going to be a function of restoring ADAMTS13 as well as understanding the mechanism of these cardiovascular complications in both diseases. So I think it'll be ADAMTS and other measures as well. Sorry, I jumped in there, Marie.
No, I'm glad you did because I'm going to hand over to Dr. Scully with the second part of this that someone brought up. What else do you do for patients with vascular risk factors, including neurocognitive symptoms, in addition to recombinant?
Yes, so obviously there are all the other cardiovascular preventative measures. Hypertension with age is not uncommon at a younger age with the congenital, so you have to be mindful of that. Ensuring their lipids are okay. We scan them not very frequently, but we do scan to make sure that there's no new ischemic evidence on brain scan in particular. And these can be quite silent, but also the white matter changes that we see. We need to make sure that we're preventing those with whatever prophylaxis pathway that we use. And it needs to be a constant review and change depending on patient well-being. Neurocognitively, to be honest, it's not the same as immune TTP. In my experience, but I think we will understand more about that with time. The neurocognitive abnormalities with regards to, let's say, depression and anxiety is more because of the long-term impact of a chronic disease and trying to deal with that and the potential, going to die earlier. But are you going to die earlier if you're going to receive ADAMTS13 replacement? So we don't know the answer to that. So I don't think they're necessarily neurocognitive. I think they are appropriate reactive anxiety and depressive symptoms that we have to manage and involve clinical psychologists.
No, thank you very much. In our remaining time, I'd like to turn to a couple of questions on reproductive health. The first is from Dr. Oliveira, who asks, which contraception choices do you recommend in patients with congenital TTP? Dr. Cataland, what's your take on this?
It's an excellent question. We're obviously concerned about the estrogen and the potential to increase VWF levels, but I think we also have to look at it from both standpoints. If we're going into a contraception or estrogen use for other medical needs, really, what is the best approach for the patient? And if an estrogen in the context of a prophylaxis program is felt to be the best by the obstetrician and the hematologist, I don't think it's unreasonable provided that protection. It's a bit of an unknown, but obviously an unwanted pregnancy may cause more potential problems for a congenital cTTP patient than the oral estrogen itself with prophylaxis. So I think it's an interesting question we need to learn more about, but I think we need to consider both sides of it, I mean, the effective contraception as well as what is safe in that patient.
Right. And the next one's for you, Dr. Scully. How do you counsel patients with congenital TTP who are not currently on prophylaxis to use recombinant ADAMTS13 once pregnancy is confirmed, given the lack of extensive safety data for the first trimester?
It's pretty easy. It's a recombinant protein. It is not a blood product. And we already have safety data with regards to efficacy and no antibody formation in the non-pregnant state. So it's easier to counsel patients than perhaps counseling them to start FFP, for which, in many countries, many areas, there are the risks of reactions. Firstly, failure to achieve an adequate ADAMTS13, which will impact fetal well-being. Now, we know they do much better with plasma, but it will impact fetal well-being potentially. So always we say it's not licensed for pregnancy. Would you receive one above the other? I would certainly, not that I'm in a position to anymore, but if I had congenital TTP and I wanted to get pregnant, I would I would take recombinant ADAMTS13, and therefore I think we should explain that to patients, and they usually feel quite reassured that you would want to do one above the other because of safety issues.
Oh, thank you very much. And I completely agree. I currently have 2 pregnant patients who were very enthusiastic about going on recombinant ADAMTS13 because they did not have good outcomes of pregnancy without it. I'm going to hand over back to Dr. Cataland now. Yeah,
Well, thank you both very
thank you.
much. We'll let you take another crack at these knowledge check questions as we're coming up to the hour where the webinar will end. You can scan the QR code to do that. There's the second one. And while you're doing that, I really want to thank my colleagues and presenters, Dr. Chaturvedi and Dr. Scully, for their participation in this webinar. We hope you found it educational and enjoyable. And also want to thank Takeda for their funding of this education initiative. Thank you all very much.